Hi guys, very good evening to all of you and welcome to our today's YouTube session which has been scheduled especially for our NEET PG and FMG aspirants. And in this series I'll be discussing about frequently asked topics in the examination, these two examinations that we have, FMG and NEET PG. Okay, so I'm not going to ask a lot of question here. I'll be just telling you some of the important topics, and on the this topic that I have chosen here is on the basis of past 5 year question that has been asked. We have summarized those topics, and this is what I'm going to discuss. So for the next few days I'll be meeting you guys on YouTube at 7 p.m. every day. Do you remember, this is a free class for all. 7 p.m. every day I'll be discussing these frequently asked topics for the next few days. Okay, so let me start this session very quickly, but before that I need to know if I'm clearly audible and visible to all of you guys. There is no poll here, but you guys can reply here. For all the students those who are new, you can reply in the comment box here. There is a live chat option that is going on. If everything is fine, okay. So let's get started, but before that, a quick reminder that if you guys are subscribing to Unacademy, please do not forget to use the code PHARMA10 to avail a 10% off. Now, one of the very recent questions that was asked in the examination, that is FMG and NEET PG examination, is on the topic that is known as your bioavailability. First and foremost, I'll be discussing about bioavailability, and likewise, as I told you that I'm having 10 to 15 topics for today, and then likewise tomorrow also we'll be having. So today's session will be mainly for general pharma and some of the important ANS topics as well I'll be giving you. So take note of these topics as well, and rest assured that if a question is going to be asked from these topics, you'll be able to do these questions very easily. Dr. Madhu, this is for general pharma, and some aspect of ANS will also be covered. Tomorrow, likewise, I'll be discussing cardiovascular system and some aspect of CNS as well. Okay? So today general pharma and some aspect of ANS. Alright, so whenever a question is being asked bioavailability, you have to know the formula bioavailability and what is the clinical implication of this one. So percentage of drug reaching the systemic circulation, that is your bioavailability, and it is inversely proportional to first pass metabolism. Always remember, bioavailability can dependent on first pass metabolism, but first pass metabolism is not dependent on bioavailability, and this has been asked in one of the examination. Okay, so bioavailability, what is bioavailability? Amount of drug reaching the systemic circulation after the first pass metabolism. Via oral route, the bioavailability will always be less than 100%. It will never be 100%. There are certain drugs in which bioavailability can be 100%, I mean close to 100%, not 100% even. So example of a drug that can have close to 100%, let's say linezolid. Linezolid can have nearly 100%, but rest assured it will never be 100%. It can be 98, 95, 99, but it will never be 100%. IV is the only route that will be having 100% bioavailability. Now, what is the clinical implication? This is for FMG also. Yes, Dr. Ruxana. This is for FMG as well. Okay. Now, what is the clinical implication that we have? I'll come back to this. Clinical implication that if a drug is having high first pass metabolism, okay, those all drugs you can give orally only if the bioavailability is enough to cause a therapeutic benefit. But usually on an average, what we say that whenever a drug is having high first pass metabolism, let's say 100% first pass metabolism, we do not give them orally. Like for example, these are the drugs down here, they are having 100% first pass metabolism, therefore they are never given orally, and you can remember them very easily. LITS, lith is a very simple mnemonic. Lith stands for lignocaine, isoprenaline, testosterone and hydrocortisone. These are the drugs that is having 100%. So we never give lignocaine, isoprenaline, testosterone, hydrocortisone via the oral route. But there are certain other drugs, in spite of having high first pass metabolism, we are still using it via the oral route. So whatever the bioavailability is there, it is enough to cause the therapeutic benefit, it is enough to cause the effect. That is why we are using. Example, propranolol, does it have a high first pass metabolism? Verapamil, does it have high first pass metabolism? Yes, right, but still we are using it orally. In the higher doses, we can use them orally as well. Propranolol, verapamil, nitrates, right, salbutamol, these are the example of a drug that are also having high first pass metabolism but still given orally. Preferred route for nitrate, it has been given here, will be sublingual, but nitrates can also be available by other routes as well, like transdermal patch, buccal route. Oral nitrates are also available for all of you guys. Okay, so this is one thing, high first pass metabolism. What will happen if there is low first pass metabolism? If there is low first pass metabolism, can you guys tell me, if there is a low first pass metabolism, what will happen to the bioavailability? There will be high bioavailability. What is the clinical implication of this one? एक तो क्लिनिकल इम्प्लीकेशन आपने ये देख लिया, if there is a high first pass metabolism, don't prefer orally, but if it is enough to cause therapeutic benefit, we can give orally. But if it is low first pass metabolism, the clinical implication is that their IV and oral dosage are almost same. Any drug that we have, if they are having high bioavailability, example of a drug that is having high oral bioavailability, like for example, let's say linezolid, right? Example of a drug that we have is linezolid, right? Or we can also have drugs like your levofloxacin. So their oral and injectable dose can always be almost same. Okay. Now what is the other topic that we are having is among the receptors. Among the receptor, you have to know and read about a G protein couple receptor. G protein couple receptor is it's a forever asked topic. It's never going old kind of topic. And under G protein couple receptor, you should know that the other name is 7-pass receptor or heptahelical receptor. Heptahelical, serpentine, 7-pass, all of them are name of G protein couple receptor. G protein couple receptor, alpha is considered the active part of G protein couple receptor, and alpha is having multiple type. This alpha that we have, it can be of multiple type. It can be GS, GI and GQ. GS, GI and levofloxacin, I said, Dr. Isaac Deepak Vishal. ठीक है. We'll talk about how to improvise GT. Dr. Pooja Shri will talk about that. Okay. Now, types of alpha that we have, GS, GI and GQ. S is the stimulatory. They will be stimulating adenylyl cyclase that is going to cause breakdown of ATP into CAMP. Guys, remember the level of CAMP is going to be high. When the CAMP level is high, they will be acting as a secondary messenger. They will be causing more and more influx of the calcium, and they will also increase the permeability of the calcium channel. Alright. Now, what are the example of receptor acting via this GS? Example of receptor, you can remember BDSH, Badshah. BDSH, beta receptor, all the beta receptor like beta 1, beta 2, beta 3, all the beta receptor is going to act via G protein couple receptor ka GS, right? Dopamine 1, 5-HT4 and histamine. Can you tell me a name of a drug that is acting via 5-HT4? 5-HT4 is one GS, right? So there will be stimulatory. Remember, they are present on the intestine, and if 5-HT4 is present on the intestine, they will be increasing the motility of the intestine. A name of a drug that you should never forget is prucalopride. Please do not forget prucalopride. Upcoming NEET PG and FMG both aspirant. Prucalopride, it can be used in a patient with the IBS, right? IBS associated with the constipation, or we also say constipation dominant irritable bowel syndrome, or in any other case of constipation, like for example opioid induced constipation. In that also you can use prucalopride. It's one of the 5-HT4 agonists. Histamine ka H2. The drugs that we are going to use as the H2 antagonist, ranitidine, cimetidine, everyone knows that, right? So BDSH, don't forget. GI that we have, they are going to act as an inhibitory, I for inhibitory. They inhibit that adenylyl cyclase, and therefore ATP conversion to CAMP will be reduced, and therefore less influx of the calcium, therefore CAMP level will definitely be lesser. There is an additional mechanism of GI that we have. They open, especially the beta and gamma component of G protein couple receptor, they open acetylcholine sensitive potassium channel. You guys know well that whenever potassium channel will open, what will be the direction of flow of potassium? There will be potassium ka efflux. Because of the efflux of the potassium, there will be hyperpolarization. Please do not forget these two mechanisms of action. An example of receptor, do remember most of the two words are coming with the GI, like alpha 2, dopamine 2, opioid, right? M2, M4 and 5-HT1, H3 and H4 also. Okay. So these are the example of receptor that are acting via GI. You can remember ADOMS. I told you BDS is Badshah, and the name of the Badshah was ADOMS. ADOMS Badshah, GI. Alpha 2, dopamine 2, opioid, M2, M4, 5-HT1 and S3H4, right? Can you tell me a drug that is acting by 5-HT1? 5-HT1, it can be divided into 5-HT1A, 1B by D, 1AP, the drugs that will be used for anxiety like buspirone, ipsapiron, gepirone, right? 5-HT1B by D are triptans, they are the agonists, right? Triptans, that is used in migraine mainly, okay? Then GQ that we have, that is going to activate phospholipase C, that will be increasing IP3 and DAG. So via IP3 and DAG pathway, which one is going to work? That is GQ. Okay, and the example of receptor acting via GQ will be M1, M3 and M5, alpha 1, AT1. Then we also have TSH, H1 and 5-HT2. 5:2 is also one of the example of receptor acting by GQ. So how are you going to remember all the GQ? Again, a very simple mnemonic that you should know, that MAATHS, maths. So the whole story says that Badshah Adams का maths is a questionable. Why questionable? Q for questionable. Badshah Adams का math is questionable, right? Maths will be M1, M3, M5, all the odd number of the muscarinic receptor, alpha 1. So if you see, most of the one word that we have are coming with the GQ. Then 5:2 का 2 variant that is coming here, but rest of the other 2 that we have are coming in the GI. So Badshah Adams ka maths is questionable. So you have to draw it again, you have to write it again, and then only you will be able to remember and recall. So don't forget G protein couple receptor, very very important. This is the representative image of G protein couple receptor taken from KDT. Then 4 types of drugs, and I'm pretty sure that all of you guys have seen this image that was asked. So last time also I have discussed a similar kind of session, and immediately 2-3 days after there was an exam and the same image was asked. Luckily, we were lucky in that time. So 4 types of drug that we have on the basis of the intrinsic activity. What are those 4 types of drug? Agonist, partial agonist, inverse agonist, and antagonist. Do remember, guys, what are the agonists? Agonist is whenever drug, after binding with the receptor, it is going to produce maximal intrinsic activity. IA is intrinsic activity, maximum, whatever the maximum response is possible, maximal intrinsic activity that we have, it is caused by the agonist, and the intrinsic activity score that we are going to give is +1. Partial agonist, drug after binding with the receptor is going to produce sub-maximal intrinsic activity, Then we have antagonist, drug after binding with the receptor is producing no intrinsic activity. It will simply occupy the site, does not allow any other one to bind and act. Okay, a very classical example of benzodiazepine antagonist will be flumazenil. Okay. Then we have inverse agonist, drug after binding the receptor is producing opposite action, right? Like beta carbolin is a very good example of inverse agonist for benzodiazepine receptor. We have multiple other inverse agonists, right? Like for example, triprolidine that we have, that is inverse agonist for S3, right? Okay, moving forward, the agonist that we have, agonist +1, partial agonist 0 to 1, right? And antagonist that we have is 0, and inverse agonist is -1. So this image, the exact image was asked in the 2022 examination. Other thing that you should know here is the 4 types of antagonist. The antagonists that we have, there are 4 types. This is the ultra important. I am putting a 3 star here over this topic again. So example will be given, different types of antagonists. Please do not forget this, different type of antagonist. So one of the antagonists that we have, pharmacological antagonist, also known as your competitive antagonist, right? Competitive antagonist. Antagonist I am using as a hashtag sign. 2 drugs, they are going to compete for the same site and produce opposite response. For example, adrenaline and propranolol. I can also give multiple other example, like for example acetylcholine and atropine, right? So how will you see? Let's say that we are having one drug, and we are having one more drug. We have 2 drugs, and these 2 drugs, they have a high affinity or similar kind of affinity for the same receptor. So let's say one drug, the name of this drug is adrenaline, and the name of this drug is propranolol, and they have a high affinity for beta receptor. Isn't that we know that when adrenaline will act on the beta receptor, they will increase the heart rate, and when propranolol will act on the beta receptor, they will decrease the heart rate. So 2 agents competing for the same site or binding at the same site, but when they bind, they have opposite response to each other. Adrenaline can cause tachycardia, propranolol can decrease the heart rate, right? So they are the example of pharmacological antagonists. Remember, the pharma guys, they are highly competitive. Pharmacological antagonists are also known as competitive antagonists. Always remember, guys, whenever a competitive antagonist is given, it will always and always reduce the potency. Very important point I'm telling you, competitive antagonists will reduce the potency, and they will always cause shifting of the graph towards the right side. I'll be showing you the graph as well subsequently. Then we have physiological antagonists, where there are 2 agonists. Okay, so we have one agonist and we have one more agonist. We are having 2 agonists, but both of these agonists, they are not going to compete with each other at all. There is no competition between them at all. They both will be acting differently at a different site, but they produce opposite action. For example, let's say this is adrenaline and this is histamine. When adrenaline acts at the beta receptor on the beta receptor of the lungs, they can cause bronchodilation. When histamine will be acting on the beta histaminic receptor of the lungs, bronchial smooth muscle, they can cause bronchoconstriction. See, adrenaline will never go and compete for the H1. No, it will always and always go here. यहाँ पे वो कभी नहीं आएगा. It will never come here. Likewise, histamine will never go up. No, it will always and always compete for, bind at the H1 receptor. They do not have, histamine does not have any affinity for beta receptor. Okay? So, histamine acting on the H1 receptor causing bronchoconstriction, they are a very classical example of physiological antagonist. Two agonists, very important term, binding at a different site but producing opposite response like adrenaline and histamine, right? And glucagon and insulin. Insulin causes hypoglycemia, glucagon causes hyperglycemia. They are two agonists. They will be acting at a different site and producing opposite responses, right? Video not clear. Doctor, try to improve your video quality. Go to the setting area of the screen and try to increase the quality of the video to, let's say, 720 or higher picture quality. Your video will improve. Dr. Raja Prabhu. Okay, another one that you should know, I think I need to add one more. Let me see if I can add one more. Okay, there is no space, so I'll just write it here. Another one that you should know is known as your chemical antagonists. Chemical antagonists are all the chelators. All the chelators are example of chemical antagonists. Example like, let's say, digibind is a chemical antagonist for digoxin. Or we have D-penicillamine. D-penicillamine, it's a chemical antagonist for copper. Okay, so what is chemical antagonist? They will chelate, inactivate the compound and promote its excretion. They will not leave until the compound is out of the body. Another one that we have, this is the third type, and the fourth one that we have is known as pharmacokinetic antagonist. Pharmacokinetic antagonist. Okay, pharmacokinetic antagonist. What is pharmacokinetic? The antagonistic activity is seen by increasing the metabolism of the drug. Metabolism of drug. Example, by enzyme inducers, right? Enzyme inducers. So they are example of pharmacokinetic antagonists. All the enzyme inducers that we have. So pharmacokinetic, what are the kinetic property that we know? Absorption, distribution, metabolism, excretion. So metabolism is one of the kinetic property. A very good example I can give you. Let's say a patient was on OCP and patient was on OCP and she was started on rifampicin. And rifampicin will induce the metabolism of OCP and that can lead to contraceptive failure. So OCP benefit will not be achieved in this patient. Okay, there will be opposite action compared to contraception. So there will be contraceptive failure. Okay. All right. So that is your pharmacokinetic. Then you should know in the metabolism there are two kinetics, right? Zero order and first order. Majority of the drug they follow first order kinetic. Only few drug follow zero order kinetics. And all the drugs that are following zero order kinetics, you can remember very easily by a simple mnemonic that unfractionated heparin, you put an end to this war. How are you going to remember? See, getting zero in an examination is like a war. If you are getting zero in any examination or anywhere, it's like a war. Take it as a war, and only you can put an end to this war. U stand for unfractionated heparin. So remember, heparin and warfarin, both of them are following zero order kinetic. But what you needed to know here once again is drugs like your low molecular weight heparin, it follows first order kinetics. Please do not be confused, and this was the question. Right, low molecular weight heparin like enoxaparin, dalteparin, tinzaparin, these are all the example of low molecular weight heparin. Enoxaparin, dalteparin, tinzaparin, arteparin, reviparin, they are all low molecular weight heparin. Okay, so unfractionated heparin, phenytoin, aspirin, ethanol. Ethanol is the only compound that follows true zero order kinetics. Okay, tolbutamide is the first genesis of sulfonamide, theophylline, the anti-asthmatic drug, and warfarin. With all of them, the risk of toxicity is very high because they follow zero order kinetic. The amount of drug that is eliminated is going to be constant, and at the high doses, the accumulation is seen with the drugs that are following zero order kinetic. So we should be very, very careful with giving these kind of drug. Okay. sorry. Then Quantal DRC, and another graph that I told you that you should know about potency and efficacy, that is important. Quantal DRC mainly, it is the response that cannot be quantified but can be said only to be present or absent, all or none response, right? So example is death. Death is either seen or death is not there, right? For example, if you're going to measure the effect of a drug and your end effect is death, you cannot say 20% death has occurred, 30% death has occurred. Either death has occurred or death has not occurred. So we say all or none response in the Quantal DRC. Likewise, in the Quantal DRC, mainly we are going to assess a safety of a drug, safety profile of a drug. Initially, when you give any particular drug, you will be achieving some therapeutic benefit or therapeutic response. When you increase the dose to multiple times, there are chances, even if it is a safer drug, let's say a safe drug as safe as, let's say, paracetamol, when you increase the dose to multiple times, it can even cause lethality, it can even lead to death as well by causing paracetamol poisoning, liver failure and death. Okay, so let's say when the dose is increased multiple times, it can lead to lethality, it can cause death as well. So when it is causing therapeutic effect, a dose that can produce therapeutic benefit in a 50% of the responder, this is responder actually, on the y-axis it is responder. So a dose that can produce response in a 50% of responder, therapeutic response, is ED50. And a dose that can kill a 50% of the experimental animal will be your LD50. And what is this difference between this ED50 and LD50? We call this one as a therapeutic index. So therapeutic index usually is a lethal dose divided by the effective dose. You can remember very easily, TLE, tile is a simple mnemonic. Therapeutic index is equal to lethal dose divided by the effective dose. Always remember, whenever therapeutic index is narrow, we say that those drugs are unsafe drugs. We should avoid those drugs as much as we can. Don't give those kind of drugs. But if there is no other option, you can give, but what you should take note that therapeutic drug monitoring is required. Always remember that whenever there is a one drug that is having wide therapeutic index, they are known as safer drug. In this example itself, if I tell you, let's say there is one drug, it is causing therapeutic effect initially, and when you increase the dose to multiple times, it will be causing lethality, it can cause death. So this is having, like, let's say, very wide therapeutic index. जो इसका safety margin है काफी wide है. So therapeutic index mainly is a measure of safety margin. It's wide. For example, if I give one more drug, just trying to illustrate one more here. Let's say there is one more drug coming here that is going to cause, lethality on the very next dose. If this is going to cause lethal effect in the very next dose, can you still call it as a safer drug? Because here the therapeutic index will become very, very narrow. This will become an unsafe kind of drug. Remember that, okay? So whenever therapeutic index is narrow, it is unsafe kind of drug. When it is wide, it will be safer kind of drug. Okay. Now TDM is required in this condition wherever there is narrow therapeutic index. So TDM is done for if there is narrow therapeutic index, if response cannot be measured via other ways. If response cannot be measured via other ways or via other investigation, in that condition you need to do therapeutic drug monitoring. What are the example of a drug that requires therapeutic drug monitoring? You can remember P-Dalit, Pyara Dalit, that stands for your phenytoin, digoxin, aminoglycoside, lithium, immunosuppressant like cyclosporine. How can you know how much of the immune has been suppressed? Tacrolimus or any other immunosuppressant, TCA, tricyclic antidepressant, and theophylline. Examiner asks which of the following antibiotic required therapeutic drug monitoring. So AG for aminoglycoside. Aminoglycoside is a highly nephrotoxic and ototoxic drug. We should keep an eye on the therapeutic plasma concentration level of aminoglycoside. Phenytoin, likewise, it is having an anti-epileptic drug. The therapeutic range that we have, it is 10 to 20. Right, 10 to 20 microgram per ml. If the level is going beyond 20, it will be toxic and follow zero order kinetics. Okay, so you should always keep an eye on the plasma concentration level of anti-epileptic drug like phenytoin or other anti-epileptic drug as well if you are going to start. Like for example, let's say carbamazepine has 4 to 8, valproate has 50 to 100, right? So these are the therapeutic plasma concentration level of these drugs. Okay, TDM is not done. That is another very important question. TDM is not done. In which scenario? If there is a wide therapeutic index, okay. Wide therapeutic index. Example I can give you, let's say penicillin. Penicillin does not require therapeutic drug monitoring. They are relatively safer kind of drug. Okay. If effect can be measured via other investigation. if effect can be measured via any other investigation, then we don't need to do TDM. If effect can be measured via other investigation. For example, if there is a patient on warfarin, you don't need to check plasma concentration level of warfarin. What you can simply do, you can simply do PT-INR. Yeah, and your therapeutic plasma concentration level, you can easily, you don't need to do therapeutic plasma concentration. You can easily assess the effect of the warfarin. Or if there is a patient on, let's say, metformin for diabetes, you don't need to check the metformin level of this patient in the serum. You simply need to do the fasting and PP or HbA1c level you can do after 6 to 8 weeks. Or if there is a patient on antihypertensive drug, you don't need to check the antihypertensive level in the plasma. Simply do the BP monitoring, right? Wherever the effect can be measured by any other investigation, you don't need to do TDM. So this is very important. Where it is done, okay, important, but where it is not done, that should also be very important for all of you guys. You should know. Important schedules, another very important topic and hot topic that we are expecting in the upcoming examination. Now this is one schedule that deals with the biological and special product. This is according to Drug and Cosmetic Act. We have multiple schedules. A to Z we have multiple schedule. It is going beyond 26, right? Because many of the schedules are having subtypes, like F has FF, H has H1, and likewise there are multiple subschedule as well. But you have to know few of them with respect to allopathy. So with the biological and special product, we have schedule C. Gives the list of poisonous substances under Ayurveda, Siddha and Unani. This is going to be schedule E. Regulation and standard for running a blood bank. So in the blood bank, everything should be frozen. So you remember like that, schedule F. The one that is going to give you guideline, that caution, if it is not for you, don't take it. It is taken under medical supervision, like hormonal, anti-cancer drugs. They are all coming under this one. Remember, this will be schedule G. This is, we are talking about intake of a drug, but here we are talking about sale of a drug, that not to be sold except under medical prescription. It should be sold only on a prescription of a prescription given by a registered medical practitioner, right? So this will be schedule H, right? Registered medical practitioner. You can remember who is the registered medical practitioner. H for hum hai registered medical practitioner. The one that gives you guideline will be schedule G. Whenever you eat any, let's say, Ayush system of medicine, they are not very palatable. They are little bitter in tasting. And whenever you eat anything bitter or drink anything bitter, what is your expression usually? Your expression will be E, right? The one that brings E from your mouth will be schedule E, right? Biological, B for biological, C for schedule C. Then likewise, we have multiple other schedule important. P for expiry period. Drugs which shall be marketed under generic name. So generic drugs are available via the same name. So they are available by the same name worldwide. So jo worldwide available by the same name, that is schedule W. Worldwide same name. Psychotropic drug that requires specific license for manufacture and sale, that will be schedule X drug. These are the psychotropic drug that require specific license for manufacture and sale, that is schedule X drug. Specify requirement and guideline on the clinical trial, import and drug manufacture. So whenever it comes to clinical trial, remember schedule Y. Okay, schedule Y that we have is clinical trial. So let's see how can you remember now and forever. Okay, specify clinical trial. So whenever it comes to clinical trial, and if someone is coming and telling, okay, please prescribe my drug, it's highly effective, it has been tested in this area, you can say, why should I prescribe your drug? You ask them very gently, very politely, why should I give your drug? He will say, let's do clinical trial, right? And in the clinical trial we can find whether this drug is effective or the existing one is effective. Okay, so whenever it comes to why, let's do the clinical trial. Okay, then psychotropic drugs. So remember psycho X. All of you try to recall, if you have an X, right, psycho X. If you do not have, make an imaginary X, and remember psycho X, right? So they are having high abuse potential as well, है ना? So ऐसे याद कर लिए, इनके abuse potential भी high होते हैं. X की बात कर रहा हूँ मैं. They have high abuse potential. An example of a drug that, let's say example ketamine, that has been asked in 2020 AIMS examination, right? Ketamine, LSD, morphine, they are having high abuse potential. So all the schedule X, they are prescribed with the XRX. Normally if you prescribe a drug, you prescribe something like this, take thou. But if you want to prescribe a schedule X drug, it is prescribed as a schedule X SA, XRX. ठीक है, याद करिएगा. W worldwide, they are available by the same name. P for expiry period, I don't think anyone will forget there. H for जो हम देंगे, this should be sold only on my prescription, हम है RMP. G for the one that gives you guideline, F for blood bank, for running a blood bank, E for क्या दे दिया, that is the list of poisonous substances, and C is the biological, right? C is the biologicals that we have, right? Biological, insulin, toxin, antitoxin. If you guys understood this, then I will tell you one more important that is known as your schedule H1. Schedule H1 is mainly for antibiotics, right? For antibiotics, to check over unauthorized sale of antibiotics. Schedule H1 that we have, it is mainly brought in existence in year 2013 to check over unauthorized sale of antibiotics. To check over unauthorized sale of antibiotics. Okay, that is schedule H1, and all the drugs that are coming under H1, do remember, if you are going to see the strip of a drug, the drug strip will be something like this, and on the left hand side of the drug strip there will be a red line coming here. There will be a red line here, and this red line is indicative that okay, this is coming under schedule H1, remember. So sometimes they can give you the drug strip. Okay, Dr. Hashirama, I will explain that graph, don't worry. Okay, so I'll ask a quick question. Let's see how many of you can reply to the answer of my question. Okay, so I'll be giving you a scenario, and you have to choose any letter from A to letter Z. Okay, all of you guys are ready? We'll have a 1 minute quick quiz. Inside the revision, we'll have a 1 minute quick quiz. Can we start? Okay, quickly. This schedule deals with the expiry period of a drug. Write any letter from letter A to Z. Which one do you think is corresponding to this answer? Expiry period of a drug is dealt by which schedule? All of you, please. Hi guys. All of you, please reply. All those who are live. Expiry period. Rao, Sartaj, Isaac, Vinit. Okay. Then that we have generic drug, sale and manufacture of the generic drug is coming under which schedule? Sale and manufacture of generic drug. Sale and manufacture of the generic drug is coming under which schedule? That is coming under schedule W. Very good. The psychotropic drug that requires specific license for manufacture and sale. Psychotropic drug that requires specific license for manufacture and sale. Psycho. They have high abuse potential. Okay. Clinical trial is dealt by clinical trial. Very good, all of you. Excellent. Clinical trial. Clinical trial. Pujashri X. Very nice. Isaac Y. Okay, great. So ये important questions हैं जो कभी भी आ सकते हैं आपके एग्जाम में. Please do remember. Now another important topic that you should know: parasympathetic and parasympathetic effect in the eye and bladder. इन दोनों एरिया को bladder and eye is very important. Bladder and eye, their effect, right? So in the eye, remember there are two types of responses that are possible. Either there will be miosis or there is going to be mydriasis. So these two responses are going to be possible. For the miosis, what is the name of the receptor that is going to cause miosis, guys? For the miosis, we have circular iridis muscle. If you see circular iridis muscle, also known as sphincter pupillary muscle, they have M3 receptor and they are going to cause miosis. For the mydriasis, we have radial muscle, also known as dilator pupillary muscle. They have alpha 1 receptor and they are responsible for causing mydriasis. So radial muscle is causing mydriasis, circular iridis is causing miosis. If you give M3 agonist itself, M3 का action will be boosted, M3 का action will be increased, and that is going to cause a type of miosis known as active myosis. So active myosis will be caused by pilocarpine. Pilocarpine is a drug, guys, that remember it can be utilized in open angle glaucoma and angle closure glaucoma as well. A rule of thumb in glaucoma, you should remember, any drug, if it is causing miosis, it can be used in glaucoma, and if a drug is causing mydriasis, it can always precipitate glaucoma. What did I say? I repeat, if a drug is causing mydriasis, it can always precipitate glaucoma, and if a drug is causing miosis, they can be used in glaucoma. Alpha 1, see, M3 is causing miosis and alpha 1 is causing mydriasis. If you block the activity of alpha 1 or if you block the sympathetic activity, what will be the outcome? Think and tell me. If you block the activity of alpha 1, the parasympathetic tone will automatically be high. So let's say alpha 1 blocker like prazosin or any other non-selective alpha blocker like phentolamine, tolazoline, they can also cause miosis, because there will be passive, this type of miosis will be known as your passive kind of miosis, because again, when you block sympathetic, parasympathetic tone will be high. Likewise, if you give a sympathomimetic drug like alpha 1 agonist like phenylephrine, there will be mydriasis, and this type of mydriasis will be active mydriasis. Now let's understand the concept of active and passive. Active is if you increase the activity of the same receptor which was earlier causing miosis or mydriasis. M3 is known to cause miosis, and when you increase the activity by pilocarpine, active miosis. Alpha 1 itself is known to cause mydriasis. When you increase the activity of alpha 1 by giving phenylephrine, this is known as your active mydriasis. Likewise, M3 is causing miosis, and if you block the activity of M3, that is parasympathetic, the sympathetic tone will automatically be high. So any drug that is M3 blocker like tropicamide, atropine, cyclopentolate, they can cause mydriasis, and this type of mydriasis will be known as your passive kind of mydriasis. Do remember, M3 is also present out of ciliary muscle. Therefore, in the M3 antagonist, you will have passive mydriasis, and in addition to that, there will also be cycloplegia. As compared to phenylephrine, there will be only mydriasis, but with the atropine, tropicamide, cyclopentolate, there will be only there will be mydriasis with the cycloplegia. There will be mydriasis and cycloplegia, both will be there. So do remember, M3 antagonist, alpha 1 antagonist, M3 agonist, and alpha 1 agonist, right? In case active myosis, passive myosis, active myosis, passive myosis, please do remember this one. Okay. Then the drugs that are M3 antagonists that we have that are acting in the eye, you can remember very easily by a very simple mnemonic. Aishwarya ke eye ki CT. Aishwarya is a Bollywood actress and she was known for her pretty eyes, right? So if you want to remember the eye, Aishwarya ke eye ki CT, do the CT of her eye and know why and how her eyes are so pretty, right? So Aishwarya ke eye ki CT will be, it has been given in the order of T half-life, right? Atropine 7 to 10 days, scopolamine 3 to 7 days, homatropine 1 to 3 days, cyclopentolate 6 to 18 hours, tropicamide 6 to 8 hours. Tropicamide, it is a very benign kind of drug. It is shorter acting drug, therefore they are mainly preferred in the adult and elderly population. And in the ointment form 0 to 7 year, we will be preferring atropine, because the ciliary muscle tone in the pediatric population is more stronger compared to you and me, right? So therefore in the pediatric population we will be using stronger atropine, right? Atropine. So atropine, scopolamine, homatropine, cyclopentolate, tropicamide. Do remember this, very important. Their side effect will be similar to any other anticholinergic drug. If the examiner is going to ask you any of them, that what could be the possible side effect of any of these and any of these drugs. So again, there will be blurring of mouth, blurring of vision, dryness of mouth, right? Atropine and all, they can also lead to increase in the heart rate, right? Tachycardia bhi kara sakte hain ye. They can also lead to urine retention. Atropine, scopolamine, homatropine. M3 itself causes increase in the detrusor muscle ka tone, and when you give M3 antagonists, there will be urine retention. That can be one of the problem. Then in the genitourinary ka, you should know, genitourinary mein, here on the detrusor muscle we have M3, and at the sphincter here we are having alpha 1 receptor. Okay, so at the genitourinary, if you give M3 antagonist, there will be relaxation of the bladder. So this relaxation of the bladder will be utilized in urinary incontinence or any other case of incontinence. Okay, so you can use the drug like solifenacin, oxybutynin, flavoxate, physoterodine, tolterodine, trospium, and derifenacin. Derifenacin is one of the vesicoselective M3 antagonists. Okay, solifenacin, oxybutynin, flavoxate, physoterodine, tolterodine, trospium, and derifenacin. These are the M3 antagonists. Do remember that if you are going to consider that, okay, this is the whole area of the bladder, there are some area of the bladder, for example, let's say I am going to highlight this area. There are some area of the bladder that are also having, beta 3 receptor, and this beta 3 receptor is also involved in the relaxation. And beta 3 agonist that we are going to use is mirabegron. There is one more that is known as your V background, right? V background, Mira background, they are the beta 3 agonists. They can be utilized in any case of incontinence because they are going to cause relaxation of the bladder. And you can remember very easily Mira background, मेरा भी SOFT, soft डर वाला डर या ब्लैडर जाता है, मेरा भी soft bladder, right? मेरा भी से एक चीज याद रखिएगा, प्लीज डू रिमेंबर, मेरा भी will be, they are both are beta 3 agonists, and sulfenacin, oxybutanin, flavocid, physotenin, and these drugs that we have, they are the M3 antagonists, right? So they will be utilized mainly in any case of incontinence. They will be causing relaxation of the bladder. Very, very important. Selective alpha 1 blocker, remember all the Zosine drug, they are drug of choice in hypertension with BPH and also in the scorpion bite. Remember in the very recent examination 2022 mein this case was asked already. ठीक है, they have a side effect called postural hypotension and retrograde ejaculation. Doxazosine दूर तक जाने वाला है, so among them they are the longest acting one, right? If there is a patient coming only with the BPH, drug of choice is going to be Tamsulosine. Remember Tamsulosine is also associated with a condition known as your floppy iris syndrome or flaccid iris syndrome. This floppy or flaccid iris syndrome can also be seen in any other alpha 1 blocker like prazosin, terazosin के साथ भी हो जाएगा. This can be seen mainly during the cataract surgery. In our usual classes, I have already explained this a couple of times. What is floppy or flaccid iris syndrome for all of you guys? Okay. So Tamsulosine was something that can be used. Silodosin can also be used, but it's a weaker compared to Tamsulosine. Okay. Prazosin, terazosin, they are the selective alpha 1 blocker. They can be used in hypertension plus BPH drug of choice. Scorpion bite may also drug of choice. Plus they can also be used in other conditions as well, like peripheral vascular disease. Other use, it can be used in peripheral vascular disease like Raynaud's, but not very effective. The drug of choice for Raynaud's is going to be, Raynaud's में we can use, the drug of choice for Raynaud's will be calcium channel blocker. ठीक है, peripheral vascular disease like Raynaud's में we can use, and it can also be used in a patient with the erectile dysfunction. Okay. So this is your alpha 1 blocker that is important for all of you guys. Advantage of prazosin, I mean any of the alpha 1 blocker, they relaxes prostate, favorable lipid profile, therefore dyslipidemia you can prefer, and again scorpion bite, I have already told you this one. Okay. Alpha 1 blocker, this also information I have told you already, that retrograde ejaculation and floppy iris syndrome that can be seen. This side effect that I told you, postural hypotension, retrograde ejaculation, it can be seen with any alpha 1 blocker, selective, non-selective, any alpha 1 blocker that is acting on the blood vessel, they can cause postural hypotension, they can cause retrograde ejaculation, remember that. Okay, this is floppy iris syndrome. When a dual signal is given at a time, that will be causing floppy iris or flaccid iris syndrome. Let's say if there is a patient on alpha 1 blocker and for the cataract surgery, a mydriasis is instilled. So when you give alpha 1 blocker, we all know that alpha itself causes mydriasis, and when alpha blocker is given, there will be one side effect in the eye, that will be miosis. Let's say later in the same afternoon, if you want to do a cataract surgery, you will be instilling mydriatic agents, so iris will be getting a dual signal at a time. Alpha 1 blocker ने miosis किया, surgery के लिए you did mydriasis, so iris is getting double signal at a time, and because of that this iris become a flaccid or a floppy, उसको we say floppy or flaccid iris syndrome, right? That is also floppy or flaccid iris syndrome. Important question about extrapyramidal symptom, this will be covering tomorrow. That is, this is a part of central nervous system. I will be covering this one tomorrow. So this will be about ANS, important ANS के जो important drugs है, and other important areas of general pharmacology. I told you that we will be doing, and I have done that already. I hope you guys have understood, and some of you have asked about the competitive and non-competitive. If you are still there, I'll just quickly tell you. For example, let's say there is one graded DRC. Let's say this is one of the graded DRC. Graded DRC. If it is going to be a competitive antagonist, remember the competitive antagonist mein graph will always be shifted towards the right side. That means when the dose is increased at the high doses, at the high dose, you may achieve the same response. You may achieve the same response, but usually this will be seen at the high dose. So this will be competitive antagonist, where the dose is actually increased and graph is shifted towards right side. Right? इसको हम बोलते हैं competitive inhibitor या competitive antagonist के presence में we can see this one. Right? Other one that we have is the non-competitive. In a non-competitive, what you can see, let's say this is the one graph x and y axis पे. For example, let's say this is one response that you have seen. The non-competitive inhibitor, they will not compete for the same site. They will be acting at a different site, and they will be causing some configurational change in the receptor का शेप रिसेप्टर का जो सेंसिटिविटी है, तो रिसेप्टर के लिए द सेंसिटिविटी और इसी द शेप ऑफ द रिसेप्टर विल हैव सम कॉन्फिगरेशनल चेंजेस, राइट. सो नॉन कॉम्पिटिटिव इनहिबिटर, इवन इफ यू इंक्रीज द डोज एट इवन एट द हाई डोज, द response will not be seen. The response will not be seen. So you keep on increasing the dose, but there will be no response, and this graph will always be lesser, right? So here the non-competitive inhibitor में the graph will come नीचे, right? So in this one, in the non-competitive inhibitor that we have, usually the efficacy is going to be decreased here. When the dose is increased, that means potency is decreased, power is decreased, because at the high dose potency is reduced, efficacy is reduced here, and graph is shifted downwards, downward shift of the graph. So this is about your competitive, this is your this is competitive inhibitor, this is about your non-competitive inhibitor. non-competitive inhibitor में ग्राफ नॉन एन फॉर नीचे आ जाएगा, competitive inhibitor में ग्राफ राइट चला जाएगा. ओके देखिए, वो Vmax अगर आप चाहें ना तो इसी से निकाल सकते हैं. बायोकेमिस्ट्री में आराम से आपको पढ़ाते हैं कि दिस इज योर मैक्सिमम रेस्पॉन्स, सो दिस इज योर Vmax, this is your Vmax response, and this will be half of the Vmax will be this one, and a dose that can produce, this is your K, this is your a dose that can produce half of the Vmax will be known as your Km, and this will be Km dash, right? So इसमें ये बोलते हैं कि if there is a competitive inhibitor in terms of this one, at the same speed Vmax will be same. Vmax is going to be same in the competitive inhibitor, but Km will be increased. Km is going to be increased. So in the competitive inhibitor, if you want to compete with the same maximum speed, you have to run for more kilometer. तो ये हो गया आपका competitive inhibitor. In this one, if this is the Vmax, if this is the Vmax that we have, then the Km that we have for this one, or half of the Vmax will be here, and this is what you are going to see. This is where you will be seeing the Km. But if you are going to look at your non-competitive inhibitor, let me just draw it. If you are going to see the non-competitive inhibitor, let's say here, and this is going to be our Vmax. I mean, ये तो आपका Vmax हो गया, और ये इसका Vmax अगर देखेंगे तो this is the Vmax of the competitive inhibitor, और इसका कहाँ पे आएगा, इसका ये इसका Vmax हो गया, और इसका अगर Km देखें तो कहाँ आएगा, ये हाफ ऑफ द Vmax इसका हो गया, एंड लेट मी चेंज द इंक कलर सो दैट यू कैन रिमेंबर, इसका Vmax हाफ ऑफ द Vmax यहाँ आएगा, एंड व्हेन यू कंपेयर दिस वन, इनका Km विल बी कमिंग सेम, देयर Km विल बी सेम, सो दिस विल बी Vmax Vmax डैश, और इसका ये Km यहाँ पे आएगा, Km और Km डैश दोनों सेम पे आएंगे, ठीक है. सो इसका Vmax का हाफ ऑफ द Vmax विल बी, half of the Vmax will be this one, so that is Km, and ये Vmax dash कौन सा है, this Vmax will be mainly the non-competitive inhibitor वाला, तो इसका Vmax कहीं यहाँ पे आ रहा है, और इसका जब आप Km देखोगे तो that will be falling on the same. So what they say, Vmax in the non-competitive inhibitor will be decreased and Km remains the same. Km remains the same, ठीक है. तो ये आपका होगा किसका, ये नॉन कंप्लीट इनहिबिटर. एक बार खुद से आपको ड्रॉ करना पड़ेगा, देन यू कैन अंडरस्टैंड इट क्विकली. इन दिस टाइम आई वाज एबल टू टेल यू दिस मच. आई होप यू गाइस अंडरस्टूड दैट. थैंक यू वेरी मच फॉर योर प्रेजेंस एंड अटेंडेंस. आई विल सी यू in our tomorrow session. Tomorrow we'll try to be a little more early, and we'll try to keep some question as well at the end, because I feel that without question these things just go like a theory class. So I'll try to keep some question tomorrow, from tomorrow onwards as well. 7 p.m. pe I'll see you again. Tomorrow I'll have cardiovascular system and CNS ka quick revision. So be here, and only the important areas in the 45 to 50 minutes I could cover, I'll be covering in our tomorrow session. ठीक है. If you want to improvise the GTC, learn from the mistake. Whatever mistake that you have done, try to check which subject is having maximum mistake. There are chances that basics are still troubling you. Try to work on the basics. And if ever you found out the problem, because 50% of the problem is most of the students don't know where the problem is. They're just giving the GT blindly and they're getting a score. Let's say sometime out of 200, if they're getting 150, they're feeling very elated. Sometime out of 200, if they're getting 70 or 80, they're feeling low. They're not analyzing that if they got 150, what are their strength and what are their weaknesses. You have to work on your weaknesses in both the scenarios. If you're getting high score or if you're getting low score, you have to work on your weaknesses, right? The strength hai, theek hai, you are going to work on the strength. You will be studying that is no doubt. But weaknesses, where you have to work consistently. You have to be consistent. You have to be persistent about that. Remember, I would say 45 minutes to 1 hour on the daily basis you have to give for your weak areas. It can be pharma, it can be anatomy, it can be microbiology. Each one of you can have different kind of weakness. Identify the weakness, right? Ask yourself, look at the GT, look at the explanation of GT, that in which subject you have made maximum mistakes, that is your weak area. Try to work on that. Just 45 minutes to 1 hour. Think that, okay, everyone is having 24-hour day, you are having only a 23-hour day, because the 1 hour is not existing in you. You are just working on your weaknesses. It can be any time. I would say in the morning, in the night time, in the afternoon. It totally depends on you, but that should be totally separate away from your usual study schedule. Work on that and do it for at least 10 days. Give another GT and let's see how far you can go here. ठीक है, GT दीजिए, 2 तरह से GT दीजिए. Try to if you are one of the NEET PG aspirant, you know the minus marking is definitely there. So you try to control your mistakes, because sometimes जब आप बहुत ज़्यादा aggressive play करते हैं, when you are playing aggressively with the questions, sometimes even if you know the question, you have made good number of correct answer, your scores are going down. So work on that as well. So try to give 2 kinds of GT. एक में आप बहुत ही aggressively play करिए, एक में थोड़ा safe play करिए. See in which GT your scores are getting better and try to follow the same. If you think that okay, if you're playing safe, your scores are getting better, play safe, right? That is how that is what you are. Your tukkas, your guesses are not working. Work on that particular skill which you are good at. If you think that okay, when you're playing safe, scores are going down, but when you're playing aggressive, okay, your scores are a little bit okay. And if you are able to rule out at least even 1 to 2 option, 2 option है तो बिल्कुल करना है. 2 option अगर rule out कर ले रहे हैं तो definitely you have to do. But even if you are able to rule out 1 option, try to attempt that question, right? Try to attempt that question. That will not be considered as playing aggressively. That is something that you have read. That is how you can rule out 1 option. Try to do that, and that is how you can improvise. It's it's not a one-day game. It's not something that I tell you and then you follow. It's a practice. It should come with the regular practice. That's what I would say. Okay. Chalo. Thank you very much to all of you for your presence, for your attendance. I'll see you in tomorrow's session at 7 p.m. Tomorrow's topic will be central nervous system and cardiovascular system. I'll revise these 2 topics, rest assured, and you'll keep these notes for the last minute revision of your examination, be it any examination. ठीक है, चलो, bye bye to all of you. Have a good night.